So basically, this talk is on decision making in acute scaphoid fractures. So we all, first thing is most commonly either miss it or the fear of scaphoid fracture is so high due to various reasons. Scaphoid fractures account almost 60 to 70% of the carpal fractures and are second in frequency of wrist fractures only to distal radius. So looking at the classification, there are various classification either by location or by orientation. Orientation sometimes even it also dictates the stability of the fracture. Why location is critical? Because this also dictates the union status of these fractures or the possible chances of non-union we get to know. That is, more proximal the fracture is, the difficult will be to the union status, whereas more distal it is, better the healing status. So waist is the mid portion of the waist fracture is the most common fracture which we come across routinely. Next, talking about the classification by orientation, it could be either transverse, horizontal or oblique, or the vertical, horizontal oblique or the vertical fractures. These vertical fractures are the fractures which have been very difficult to manage because the shear flow forces are high, whereas transverse fractures are much better. Horizontal oblique also can be relatively better. Another classification is by Herbert's, which is basically, as I told, stability. Based on the stability, it is classified, whether it is stable acute fractures or unstable acute fractures. And further classification goes into C and D, whereas it's delayed union and established non-union. So what are the potentials for healing on means what is the healing depends on? Basically, it finally dictates what is the fracture location, vascularity and stability. So these three things govern the union status of the uniting nature of the fracture. What do we fear about? Again, that is non-union. Next is non-union. What is the percentage? Non-union occurs in almost about 10% to 15% of all scaphoid fractures. Why is this risk of non-union so high in these, and what are with the risk increases? The delay of treatment for more than 4 weeks, proximal pole fractures, fracture displacement greater than 1 millimeter, osteonecrosis and tobacco use. All these are a predisposition of the risk of non-union increases. Next, what else we can see whenever there's a scaphoid fractures? That is a disc deformity or the dorsal intercalated segmental instability. Whenever the SL angle is more than 60 degrees and the capitolunate angle is more than 15 degrees. That is one of them. And also there is a problem of humpback deformity. We might see sometimes the scaphoid fracture union, it shows beautiful union at the scan, but still the patient persists to have pain in the wrist. So that could be because of the humpback deformity or the intrascaphoid angle, which is more than 45 degrees. Normally it should be within 24 degrees. The non-union rates, what are the non-union rates when you talk about undisplaced waist fractures treated with casting alone has got almost, in spite of this thing, 5% to 12% the non-union rates, and displaced scaphoid fractures treated non-operatively, almost 50% scaphoid non-union rates. A lot of these statistics are mainly from the European literature, but this is where they treat aggressively. And what is the non-union? The rate of the scaphoid non-union ranges from 4% to 50% depending on the fracture type, displacement and treatment modality. Increased rates of non-unions are seen in non-displaced fractures, missed or managed without immobilization, and displaced fractures larger than 1 millimeter displacement, proximal pole fractures, early signs of osteonecrosis and humpback deformity and a vertical oblique fractures. What do these examination findings typically show us? Any wrist injury, a patient comes with a swelling, you have to suspect scaphoid fractures, because normally any fall on outstretched hand without an obvious fracture which is seen, if it is not seen in the distal radius fracture is not seen in X-ray, that means you have to have a high element of suspicion. And this swelling can be noted only by comparing with the opposite side, because a lot of times we miss out comparing them. That is where the fracture we tend to miss. And tenderness, where exactly at the tuberosity or the anatomic snuff box or the proximal pole of the scaphoid. These are the typical clinical examination findings which we should try to elicit. Next comes the X-ray. What are the X-rays we see? So typically we take PA view and lateral view. But however, we should not always, whenever you have doubting, you take another couple of views extra, that is PA view with ulnar deviation, 45 degrees pronation view and 45 supination view. Because of the twisted profile of the scaphoid, we generally tend to miss these fractures. What is the incidence of these fractures? Almost waist is 40%, proximal pole 20%, tuberosity is 10%. Up to 25% of the scaphoid fractures are not visible on initial radiographs. This is really an alarming thing. We should always, as I told, the element of doubt should be very high. And failure to treat these stable fractures within 4 weeks increases the non-union rates. MRI is the best to determine whether there is an occult scaphoid fracture. The specificity is almost 90% and sensitivity is anywhere between 90 to 100%. I'll just show some of these cases like simple fractures and a scaphoid waist fracture. So this gentleman has a fracture around the scaphoid waist. You can see now it's undisplaced. Clinically, typically he had a tenderness there, undisplaced. Day 15, you can see the fracture line is more evident here, whereas initially it was not so obvious. 8 weeks down, managed totally conservatively with this thing, completely healed fracture with a scaphoid cast. So aggressive management, that is aggressive conservative management proposed by Dr. Joseph Diaz et al. Is what we commonly this thing. But to do this aggressive management, we have to be more cautious. Where that is, we have to take all 5 possible views of X-rays. We have to take. If you cannot, then you will have to repeat the patient sometimes, if not an acute setting. Again, call the patient after 2 weeks. Initially, manage with a thumb spica cast or a splint, and then call him after 2 weeks. Repeat the X-rays. If at all, if patient is more doubtful and he is inquisitive to know more, there's no harm in doing an MRI straight away in the first time when you have a doubt, because that shows the fracture line much better. So Joseph Diaz et al. Is the one who propagated this aggressive conservative management. That means where all undisplaced fractures or a displacement less than 1 millimeter displacement, he suggested to manage it conservatively with a cast and repeat X-ray after 6 weeks. Or if you have a doubt, you can even do a CT scan to confirm the union status. The healing rate of an undisplaced scaphoid fracture with a cast immobilization is almost 88% to 95%, provided the treatment is started within 3 weeks. So this is again important. How long can we wait to start? That is 3 weeks undisplaced, a very good role and excellent union rates you can achieve. Operative versus conservative. What is the union rates and when is the early? So operative chances doesn't mean always it heals well. It is the early return to work is most commonly seen with the operative treatment, but also has a higher complication rate. Conservative, this thing we could manage with a short arm or the long arm cast. And next is what is the commonly preferred? We usually prefer short arm cast to include thumb or not. I generally include the thumb to prevent further displacement. But there are a lot of centers in Europe where we see they don't include, they just put a short arm cast. And what is the duration? Typically a waist fracture, around 6 to 8 weeks of immobilization is recommended. So this is a general algorithm when we see scaphoid waist fracture. When you have a suspected undisplaced scaphoid fracture and clinical and radiological evaluation and below thumb spica cast for 6 weeks if you have, re-evaluate after 6 weeks. That is if your clinical evaluation goes with anatomical snuff box tenderness or if you can see a bridging fracture gap. And if there is a tenderness and a fracture gap of more than 2 millimeters, then it is always worthwhile fixing percutaneous or open fixation. And again, assessment after 3 weeks. If you have an element of doubt, even with an X-ray, then it's always advisable to get a CT scan. So less than 2 millimeter, continue the cast. More than 2 millimeter gap, percutaneous fixation is best. And clinical examination gives us more information. As soon as we take off, look for the tenderness in the scaphoid anatomical snuff box. Next is the decision making. So what do we do when different areas of fracture? Distal tubercle fracture, again short arm cast 6 to 8 weeks undisplaced. Distal third fracture or incomplete fracture, again 6 to 8 weeks. Waist, a short thumb spica cast. Some people even fix mini open fixation, but I would always try to fix with, if it's undisplaced, a short thumb spica cast. Proximal pole fractures, non-displaced, always fix. Proximal fracture, always fix, especially with a screw fixation. That is the recommended because there's a very high chance of non-union. So unstable fracture, when do you call it as unstable? When there is a displacement of more than 1 millimeter, lateral interscaphoid angle of more than 35 degree, bone loss or comminution, and perilunate fracture dislocation, or a disc deformity of more than 60 degrees and capitolunate angle of more than 15 degrees. So these are the ones which we always tend to fix the fractures, unstable situations. Next, when talking about the fixation, there are two ways, whether you percutaneous fixation or the open fixation. I'll show a few photos on the slides on about the open fixation. I'll also show about the percutaneous fixation, a video technique. The most important, whether you fix percutaneously or open, what is the trajectory we want to take? That is very critical. So the most ideal trajectory is the green line. That is what is the ideal trajectory what we want. But whenever on this area, the tubercle of the trapezium tubercle is which obstructs to gain access to this level. So it might be difficult. The next point which also determines the trajectory is the orientation of the fracture. In this situation, again, waistline, would be the ideal one, the green line. But if at all a proximal pole fracture is there, a short screw is also sufficient, provided it is perpendicular to the fracture orientation. So what is the starting point? Next is whenever we are seeing on a C-arm, the lateral 1/3 and the middle 1/3 junction is the usual ideal starting point to start the scaphoid guide wire. So what is the position we use? We always try to use a block like this or the folded sheets and extend the wrist from the volar side. So that opens up a little bit of the scaphoid tuberosity. That would be the ideal starting point, because this is what I was telling, if you keep it straight, this tuberosity comes in way. So you have to open a mini open here and then try to pass this. This is the true axis and this is the trajectory which generally we pass the scaphoid screws. What are the pearls and pitfalls? Place the guide wire as centrally as possible in the scaphoid and always consider using an anti-rotation wire. Common errors is using a screw that is too long or too small also. So what we should, once we measure it, we have to subtract at least 4 millimeter from the measured distance, and a common screw length for an adult is generally a 20 millimeter. So anywhere you're trying to shoot about 20 millimeter, if you measure it, that means something could be wrong. You have to recheck it, confirm it. And do not ream past the far cortex or else you will have instability again. So if a feeling of lot of resistance, especially when the reaming over the wire, stop and look, because the wire might be bent or even broke, or the drill bit might have been broken. So this is quite often when you use, especially since this has got a very thin drill bit, and you could always break the drill bit there. And the other thing is beware of the hoop stresses. Use countersinking to avoid excessive hoop stress that can fracture the near fragment, and consider using the joystick to gain reduction. There are various maneuvers to do this reduction. I'll be just speaking in the live in the video session of that. If needed, you can reduce the pin, the lunate in neutral position. This is a very interesting technique so that you prevent out of dizzy and also aids in control of the proximal fragment. Consider a supplemental fixation for more stability if you want. What are the approach? Volar approach or the dorsal approach? I'll be showing the volar approach. This is a typical distal volar extended Henry's approach that is most commonly used for the distal pole fracture or even humpback deformity if the patient has, and preferred for waist and the distal fractures, preserves the dorsal blood supply. This is a skin incision. That's an extended Henry's incision or the lazy J incision. Once you do that, radioscaphocapitate ligament is seen and the fracture is typically behind this. So this is the ligament which we have to be careful, because we will have to divide if we have to go to the waist level, but we'll have to repair it adequately or else you'll have instability in the wrist joint. So this is skin incision. That's the FCR tendon, the white structure there, then the ligament there. So you divide the ligament and then you approach the fracture site there. That will be the proximal pole and the distal pole. Once you see that, you can open up the fracture site there So this is opening up of is very critical because the scaphoid distal pole tends to flex over itself, forming a deformity. So screw fixation. This is a typical percutaneous screw fixation. What we do, a case pre-op. This is the X-ray waist fracture. That's the entry point what we choose. So this we already discussed about this extended wrist position, percutaneous screw fixation. See in all the views, PA, oblique, lateral views, 8 weeks, good union status. So conclusion is this: study the X-rays properly. Do not hesitate to get an MRI if required to confirm the fracture. CT is useful to check the displacement and the union status, not to identify a fracture. Aggressive conservative management is the most common preferred. Be versed with both the volar and the dorsal approach. I'll just show you a video of the percutaneous fixation. So this is an individual with a scaphoid fracture presented almost 3 weeks after the injury. Initially, it looked like first it was, these are the older X-rays, but later on it showed a gross displacement in oblique views. So this is an important tip. Why I'm showing the guide wires straight, because as soon as we drape and check, we have to check the guide wires. This is very critical. Your nurse will not know whether these guide wires will be passing through the screws, because this typical procedure takes not more than 15 minutes. But you can get badly stuck inside the OT, provided if you don't check these things. First is check the guide wires, because your vendor might not have given a proper guide wire, or he might have given a used ones like this wires. I typically showed specifically because this was somebody had used and already there was a cut mark. So there's a high chance that the guide wire can break inside. This was also used and multiple reamings were done. So this should not be used. So you have to check whether it goes both through the drill bit and the screw as well, and as the screwdriver as well. All 3 points. These are the ways, because a lot of times these drill bits are so thin, the cannulated drill bit, either the bone must be blocking that, or even sometimes a broken guide wire must have already been left. So please check this before we venture on, or else you'll have problems while managing that. Next is, what is always the problem? What we find is the screw length also is sometimes an issue, if at all, for a beginner especially. So as I told, always try to get a 20 millimeter minimum size. Whenever that size exceeds that, you need to check. So how will we get a rough estimate of fixation even before measuring it? So this is what a cadaveric study which I did at Ramaya, because useful of anthropometrics. So just like whenever we are doing all these scaphoid fractures, or we typically extrapolated this orthopedic knowledge into these, because whenever we want to do a tibia nailing, we tend to see what is the tentative length of the nail of the tibia or the femur. So I did this cadaveric study wherein we assessed the length of the scaphoid with the phalanx, and that showed that the middle phalanx. So this was the cadaveric dissection. These are the soft cadavers, fresh frozen cadavers. This is a scaphoid length, and these are the lengths of the middle phalanx of the index, middle finger, ring finger, and little finger. So size match was quite consistent. The length of the scaphoid matched with the length of the ring finger, middle phalanx. So this is what is so coincident. So whenever you do an X-ray in the PAC system, if you take a PA view of the wrist, sometimes they also include the hand as well, which is not required, but they might. So you measure the length of the phalanx, because this is a straight bone, it's easy to measure. This measurement will be the length of the scaphoid. So you can subtract 4 to 5 millimeter from that and try to use that for the fixation. So this is how typical position user, I use a tourniquet. This is what I do generally. I try to put a wire, neutral wire, so that I could correct the disi deformity of the lunate before I tried. That also gives me a very good control of the proximal poles. That is basically an indirect reduction. So I pass a K wire across the radius to the lunate and stabilize, check in the lateral view as well. And this is how I mark the entry points. That is 2 views, PA and lateral views. This will be the axis of the AP view, this is the axis of the scaphoid, and in the lateral view, this will be the axis. So that gives me the direction orientation. So you can use for percutaneous, you can use a 16 gauge needle. This needle will not be available in the usual set, so it could be with the urologist where they use. Don't use 18 gauge, your guide wire will not go through that. So you can make a small percutaneous incision, then you pass that guide wire, check it in all the views. So once you do that, you could use a depth gauge measuring device, or you could use another equal size K wire and measure it and check the wire. Next is you have to use a cannulated drill bit. So this one you could either use the drill bit. A lot of them are self-tapping. You may not require this as well, but I find because a young individual, a good bone stock, so I use this cannulated drill bit. Be careful, don't try to toggle your drill bit because it can break again, which is possible, and don't apply too much of force. So once you drill that, you check the screw length. There are various types of screws available in the market, but always try to use 2.4 mm. And Indian made screws have one of the issue is the shaft's diameter is quite thick, so you have to be careful if at all using. Whereas some of the companies are only available which gives a good shaft diameter, so 2.4 mm. There are the screws which are available short thread and long thread. You could use, typically I use a short thread unless required a long one. So this is the headless screws of the Synthes, which is shown there. So you should note these things. The minute you start this thing, there are three lines: green, yellow, and red. That this is very important to note that, because as you drive the screwdriver slowly, you can see that once you take a closer look of that, you can see this is getting buried there. So once it stops at the red level, that is where you should see that the screw is countersunk and you have to stop there. So you take out those guide wires from all the angles, from both the lunate and this thing, do a fluoroscopy. You could do a continuous fluoros and check it whether the position, whether the reduction is good and whether the screw length is accurate. This is very critical because a lot of times you might feel some view, the screw might be adequate, but later on you might find that this is what is projecting somewhere. So this is very critical to check that. And while passing the drill bit also, you could take a couple of views to assess the position of the screw. So this is the post-op, immediate post-op views of the scaphoid fracture fixation screw. So this is another case, a small incision less than quite displaced. So even though it looks so much displaced, it can be close reduced. This patient was almost 4 weeks, but still we managed to close reduce it by basically the technique which we use to stabilize the lunate, correct the DESI deformity, then stabilize that, then percutaneously fix it. So this is a well-reduced scaphoid fracture. You can see bang in the middle. And you can note this because the fracture was, I have taken off the small part of the trapezium here as well. So that gives me better access towards the better orientation. This I don't do it routinely, but sometimes in this fracture, because it was a bit delayed, I had to resort to this. So this is what is about the scaphoid, acute scaphoid fractures.